Hi, my name is Tori and I am a doctor of physical therapy specializing in pelvic health and pelvic dysfunction, which means that I treat issues that can go wrong around the pelvis. So bladder issues, bowel issues, sexual dysfunction, pelvic pain, that sort of thing. One of the topics that I really wanted to talk about is what to expect after prostate removal or what to expect post-prostatectomy. Now, this isn't me saying that physicians and surgeons and other healthcare providers don't talk to men about what to expect after the surgery. I'm sure that there are some healthcare providers that do. However, I treat men both before prostate removal for a little bit of prehab, 6 weeks post-op for whatever it is that they are presenting with, or sometimes years after the prostate removal for leftover symptoms that haven't resolved yet. And more often than not, I find that the men that I treat have only been told about one, maybe two of the things that I want to outline in this video. I am a strong proponent of autonomy over yourself, of understanding your body, of knowing what goes on when you have a surgery, of knowing what to expect after the surgery. And I think that because prostate removal, prostatectomy, is often the surgery that accompanies a diagnosis of prostate cancer, that some of these details get glossed over. Prostatectomy is the first line of defense. If you've been diagnosed with prostate cancer and that cancer is contained within the prostate and hasn't spread anywhere else in the body or metastasized, then removing the prostate ultimately makes you cancer-free. And so choosing the prostatectomy, choosing the prostate removal is more often than not what I find at least the men that I treat do choose to do. And therefore, I very much want them and anyone watching who either is going to have their prostate removed or is currently chewing over getting a prostate removal, I want you to know what to expect and what could potentially happen and what will definitely happen after the surgery. Now, I've got 5 specific topics that I want to run through. They're in no particular order other than what I think makes the most sense to talk about anatomically. I want to describe what's going on in the male pelvis, describe what's going on with the surgery, and then roll into these 5 things, and that's why I've chosen the order that I've chosen. If there is one particular topic that really stands out to you, I will have a table of contents in the description, and you can skip to that topic if you'd rather just focus on one rather than all 5 that I have laid out. So without further ado, the 5 topics that I want to discuss today. Number 1 is change in penis length. Number 2 is dry ejaculate or no longer being able to have a wet orgasm. Number 3 is erectile dysfunction. Number 4 is leaking urine, urinary incontinence, leaking pee, and number 5 is risk for a hernia. Now, I think that it makes the most sense to talk about anatomy, to talk about male pelvic anatomy so that we can break down why these different topics would occur after prostate removal. So I drew a cross-section to the best of my abilities of a man. He is facing in this direction and he has been cut down the center like this. So let's visit that image together and start breaking down some of these topics. Okay, so here we have my cross-section of a man. We have got the penis here in the front. We have got the scrotum here with the testicles. And here in the back, we have the anus connected to the rectum. So you can imagine this man's pubic bone would be here in the front, and this man's sacrum and tailbone would be here in the back. So let's talk about what we're looking at exactly. So what we've got going on are a couple of different things. We have got this orange tube right here. This is supposed to be your urethra. This is the tube that connects from the tip of the penis to the base of the bladder here. This is the tube that you pee out of. Here in green, we have got the prostate, which you can see at least some of the urethra is kind of one with the prostate here. Here in purple, we have got your seminal vesicle. This is a gland that excretes lubricant into semen. And here we have the testicle in pink and the epididymis in red. With ejaculation, what's happening is you have your sperm coming out of the epididymis and traveling up the vas deferens, which ends up connecting with a tube from the seminal vesicle. And so you end up getting your sperm from the epididymis, you end up getting some extra lubrication from the seminal vesicle, and then both of those things dump into the urethra and come out of the tip of the penis. And that is ejaculation. So with all that in mind, the very first topic that we were going to talk about is penis length. Let's imagine that I am going into a male pelvis and I am removing the prostate here. If I remove the prostate, that means that I have to remove part of this man's urethra as well. And so what ends up happening is the urethra is shorter. It gets sewn together here at the base of the prostate and here at the base of the bladder. So you can imagine if you were going to lose part of your urethra and then the very tip of the urethra here was going to be sewn together with the base of the bladder here, that you might lose a little bit of penis length. You might get a sort of scrunch, pool together that ends up making your penis just a little bit shorter. So that is an incredibly normal and expected outcome of a prostatectomy. Thing number 2 that we were going to talk about is dry ejaculate. So let's revisit what we just talked about. We just talked about how part of the urethra is one with the prostate. We just talked about how you get sperm from the epididymis that travel up the vas deferens and end up dumping into the urethra. We just talked about this seminal vesicle that lubricates some of that sperm and how you end up getting sperm, some extra lubricant, and the sperm and the lubricant kind of travel into the urethra together, and that exits through the urethra out through the tip of the penis. If you remove the prostate, there's no real way to spare that seminal vesicle, and there's no real way to spare the connection between the vas deferens here and the urethra here in the prostate. And so what ends up happening is it's not that you lose the ability to orgasm, you can still orgasm. However, when you orgasm, nothing comes out of the penis anymore. This is dry ejaculate, aka not being able to have a wet orgasm. This is an incredibly typical, normal thing to happen after a prostatectomy. There's really no way around it. If you're going to get your prostate removed, you might have a little bit of change in penis length and you won't be able to have a wet ejaculate again. Number 3, the next thing that we were going to talk about is leaking urine. So let's talk about the mechanics of that. Like we talked about, what's going on here is we're removing the prostate here, which means that we are removing this part of the urethra that kind of lives in the prostate. When that happens, the base of the bladder and the remaining urethra are kind of sewn together and held open with a stint or a cath. A lot of nerves that are responsible for maintaining your continence, for maintaining your ability to control your bladder, are compromised to a certain extent when you get your prostate removed. That's not something that we have a lot of control over. However, what I didn't draw in this picture is you could imagine pubic bone would be somewhere here. A really simplified version of the pelvic floor would be kind of like a hammock, like this. Part of your ability to control your urine, to control your bladder, comes from your pelvic floor. Now, there's not much that we can do in the means of nerves that have been compromised or injured due to the prostate removal, but there's a lot that we can do when it comes to the pelvic floor and rehabbing the pelvic floor. Part of continence has to do with those nerves, has to do with your autonomic nervous system, which means something you have no control over. And part of it has to do with that pelvic floor and the pelvic floor's ability to control the urethra. Here's the thing with urinary incontinence. The numbers that we have in the literature are all over the place. Some research studies will tell you that there's less than a 10% chance that you'll have urinary incontinence, and other Other research articles will claim it's over an 80% chance. It depends entirely on the definitions of the study. It depends on who's defining incontinence and how they're defining incontinence and that sort of thing. My experience has been all over the board. I have seen men that have gotten their prostate removed, gotten the catheter out like 10 weeks post-op, come to me 6 weeks post-op and don't really have a lot of incontinence at all to speak of. And I've seen men with the exact opposite reaction going on, where 6 weeks post-op they're still wearing diapers and having uncontrollable leakage. And so when I see men before a prostate removal, I tell them that. I outline what I've seen clinically. I tell them the research is kind of iffy, we don't really know, because you deserve as a human being to be aware of the potential outcomes, to be aware of what could potentially go on. So here's what I want to say about urinary incontinence. I want to say two things. Thing number one that I want to say is when you get your catheter removed, this happens anywhere between 3 to 10 days post-op, bring some pads with you. Go to Walgreens or CVS or any other pharmacy and look for pads that are specific to urinary leakage, and bring some with you when you get your catheter removed, because some men will experience immediate incontinence once that cath is removed. And I think that it saves a lot of embarrassment and emotional heartache when you are prepared for it, you have the pads with you, and if you're leaking, you can just go on your merry way, go home and not worry about it. Then if you go, you're not prepared for it and you end up leaking, and then you have to go to a pharmacy and get some pads or drive home with wet pants or whatever. That's thing number one. Thing number two is that the research that we do have in training your pelvic floor, which we talked about, part of continence has to do with those autonomic nerves. It's not under your control, but part of continence has to do with your pelvic floor and your pelvic floor's ability to control your urinary sphincters and your pelvic floor's ability to support the organs that live above it and things of that nature. Now, your pelvic floor is something that I, as a pelvic provider, can help you rehab. It is something that we know from the literature. If you go and see a pelvic provider, a pelvic physical therapist, 6 weeks post-op, get assessed for your strength and your endurance within your pelvic floor, get on a sort of exercise program that matches where you are, then we can regain continence sooner. Thing number 4 that we were going to talk about is erectile dysfunction. Now, I think that this is a really important topic. Here's what I want to say about it. I want to say that erectile dysfunction is a common symptom after prostatectomy. When your prostate is removed, even in a nerve-sparing procedure, there are nerves that control erections that get compromised. Here's what we know. We know that it takes between 1 to 2 years for those nerves to regrow, for those nerves to rejuvenate themselves. So erectile dysfunction for 1 to 2 years post-op is expected in a way. The other thing that we know, we have some semi-promising research. It's still being investigated, but there are some physicians, some surgeons that will use Viagra and other erectile dysfunction medication directly after surgery to try to get blood flow back into the penis. Most of the time, erectile dysfunction after a prostatectomy really has to do with the ability of blood to get to the penis as opposed to the musculature that's in charge of erections. So there's not a lot that pelvic physical therapy can do in the means of erectile dysfunction after prostatectomy, at least not that we can prove in the research. And then this use of Viagra and its like meds for getting blood to the penis after prostatectomy, it depends on the physician, it depends on who you're reading, it depends on the outcomes that your specific surgeon has seen or hasn't seen with that kind of intervention, but it is a potential option. More than anything, what I can share with certainty is that it does take 1 to 2 years for those nerves to regrow, and so erectile dysfunction for the first year or 2 years post-op is something that I do see in the guys that I treat. But what I will say is that if you start waking up with morning erections, that's a really good sign about the return of that blood flow, the return of the nerve's ability to create erections. So if you're getting a morning wood, that is a really good sign. Okay, last big thing that I really wanted to share is risk for a hernia, specifically an inguinal hernia. If we're looking at my abdomen right now, and right here are my hips, your inguinal canal lives right here. So an inguinal hernia is a weakening of the connective tissue here that ends up in a bulge of the tissues, kind of right above the pubic bone on either side, right or left. After prostatectomy, you're at a higher risk for a hernia. So what's really important is that you, one, are aware of this, and two, do what you can do to not strain. When I say strain, I'm talking about inhaling, holding your breath, and pushing. So different things that you might accidentally be straining with. A huge one is constipation, especially right after you have your surgery. If you're on opioids, you might get constipated. So you really, really want to, one, manage your constipation, and two, when you go to the bathroom to defecate, make sure that you can breathe. Do not force a bowel movement, because you might end up with a hernia, which also is a surgical repair, and you just don't need it. You just had surgery, you don't need another surgery on your docket. Other places to look out for a potential hernia would be exercise. Like, let's say 6 weeks post-op, you get cleared to do whatever it is that you were back doing. If you are someone that is weightlifting or doing a lot of heavy body work, I highly, highly recommend that you make sure that you can breathe through what you are doing. If you can't exhale while you are exerting yourself and you have to hold your breath in order to accomplish a movement, you shouldn't be doing that movement. You need to tone it down, you need to modify it, you need to make it easier so that you don't accidentally end up with a hernia. So my major things for hernia risk would be, one, manage constipation, do not strain while you're defecating, and two, if you're someone that's working out and you're doing weightlifting or a lot of intense body work, make sure you can breathe. All right, that is everything that I wanted to talk about. Thank you so much for watching and for listening. I really hope that this information was helpful and empowering. I can't recommend pelvic physical therapy, at least post-prostatectomy, at least 6 weeks post-op enough. It really can help, especially with the incontinence. And worst case scenario, you go to a pelvic provider, he or she looks at your pelvic floor and clears you and just tells you that you don't have any strength or endurance gains to be made and that you're good to go. If you have a more progressive surgeon, you could also potentially see a pelvic provider before your surgery and get a prehab exercise program. If you think about any other surgery, think about a total knee replacement and think about the muscles that live on the front of your thigh, your quadriceps. If you're gonna get a total knee replacement, your quadriceps are gonna undergo trauma. We can prove that if you prehab your quadriceps, if you build the brain muscle connection between your brain and your quadriceps before the surgery, it's easier after that trauma to wake them up, if you will. The same thing's true for your pelvic floor. If we can make a prehab pelvic floor program where we are training the strength, we're training the endurance, we're training the breath work, where your brain and your pelvic floor are really connecting with each other, it's much easier to wake up those muscles after surgery as well. So I can't recommend pelvic physical therapy at least 6 weeks post-op, if not pre-op, enough. Again, thank you so much for watching. Please, please, please ask questions, post critiques, questions, concerns, comments, anything below. I will write an article about this, so there will be a link to that article also in the description. Check that out if you'd rather read what I've been talking about instead of listen to me talk about it. And I'll also provide a link for the pelvic physical therapy directory so that if you think that pelvic physical therapy is something that could be beneficial to you, you can find a provider in your area. I hope that you have a wonderful rest of your day, and thanks again. Bye.